I had a question from one of you guys in your year group since last week, very much along the lines of what I'm inviting around this loading stuff for next week, next class. And that as a reward is what I'm going to use this time as interactive time, because I think that it will have great value for not just the student who sent it to me, but for all of you. Okay, and they sent me this paper and asked me how we go about simplifying and being able to get across these concepts like the embodied predictive processing theory of pain. Now, this is a long paper, and I will upload it for other people to see. I think it's a very relevant construct or idea to be able to wrestle with, because this really does marry up with the contemporary theories around working with people from a rehab perspective. So the paper is in there, and it's going to be all about shifting this definition of pain from a sensation to a perception. And that is so important, because I think that that is really what the whole of a contemporary approach to evidence-based practice is really pointing us towards, is the fact that if pain was a sensation, then it would be the same every single time. The same input would be the same every single time, but it's simply not. We've got so many levels of moderating an input of a nail going into the hand that we've looked at through some of the pain neuroscience education. And I'm going to, again, I'm going to take control of some of the time now. I'm assuming all of you guys are going to be in different places, probably at home. Some of you are maybe still in bed. Some of you have maybe been up and run a marathon already. Everyone's in a different place. I'd like to get comfy for the next 15 minutes, because I'm not going to say to you, have you seen this video? We're going to sit and watch it, and it's going to be from one of the leaders in the field, very, very prominent person who's influenced myself, because he is one of the smartest brains out there. It's a chap called Mick Thacker. Okay, and I'm going to play his TED talk, which is him presenting this concept of pain being a perception, not a sensation. And I think it's so rich with information for you guys that in the time that you are giving your valuable time to being in this class, I won't be saying, have you seen this? We're going to have a look at it, and then I'm going to show you how we might, or I might use a way to try and translate that to work with a real person who's come to see us for back pain. Again, if we can shift across the chasm ourselves to that back pain that I may have, that you may have, is a perception, not a sensation, it totally changes the way that we're going to manage it. It totally changes the way that we're going to manage it. Because if it's a sensation, then the interpretation is going to be that it's a danger message, that it means rest, back off, and gradually get going, which, as we've hopefully all come to terms with, makes sense for an ankle sprain. It makes sense for things that cut that injury nociceptive based mechanism. It doesn't make sense for the vast majority of aches and pains. So this hopefully will open up the Pandora box of the different things that could be utilized for clinical management, none more so than top-down modulation and changing the meaning of pain, because the exercises and the interventions that come off that then are limited only by your creativity and imagination, not limited by your 20 years of not having clinical experience. You would be able to share this video and these ideas married up with some of the stuff that I've put into this module already, like the Tasmanian pain booklet. And again, I'm trying to expose you to the real leaders in the field of what we're trying to do to work with people in pain. So this TED talk, I'm going to share, and I hope that it translates through through this Collaborate, and then we'll go on to implementation of the material after any questions or anything you guys might have, because I'm going to make a sweeping assumption that you haven't seen it. If you've got this on loud, maybe have a cup of tea. I've got one here now. Let's have a nice chill and listen to somebody very smart talking about what pain might be about.
Hey everybody, it's Tony Robbins. How are you? That's probably the most loaded question you can ask somebody in the last 2 years. No matter how strong you are, it's been one of the toughest and most challenging times in most people's lives. And I'm reaching out to you because you and I both know.
Okay, yeah, just getting it sorted. And no, it's not Tony Robbins. I'm going to be playing for you. I will mute my mic, and if you could just give me a bit of quality feedback in the chat box as to whether this is translating for you guys visually or and sound wise.
Thank you for having me. Today I'm trying to convince you that pain is actually a perception and not a sensation. Here's a photograph of Andy Murray after the Washington Open in 2018. And the commentator thought that Andy Murray was overcome with the emotion of victory. But in fact, later on, Andy Murray went on to describe that this was the point at which he felt he was broken. He was broken by his pain. Andy Murray had developed persistent pain in his hip. No treatment seemed to be working. And this is what he said about it. It was consuming like all of my thoughts. I was worried about it all the time. Unfortunately, Andy Murray's not alone. Some 40% of the UK population and 20% of the world population live with daily pain. This has led the World Health Assembly to declare that pain relief should be a basic human right. So let's try and discover what we mean. What is this thing called pain? So the old idea of pain, as my intention suggests, is that pain is a sensation. And this really dates back to the time of the French philosopher and neuroscientist René Descartes. He gave the idea that we have specific pathways for each specific stimuli we're able to feel as human beings. In this case, he was depicting what he called the pain pathway. But he also described similar pathways for touch and for vision. And what he really was getting at was that whenever we have one of these stimuli, it will always produce the same response. But I want you to consider this. This went viral in the internet a couple of years ago. This dress, we had people sat in the same room looking at the same image, not able to decide really what colors it was. I can never see the true color, which is black and blue. Most people actually didn't see the real color. They saw the white and gold. But if Descartes was correct, everyone looking at that image would have seen exactly the same colors. So I would suggest that the ideas of Descartes, which still dominate our understanding of pain and its management, should firmly be put in a non-recycling bin. So what is this thing called perception? And why is pain a perception? So let's delve into what perceptions really are. This is an image taken at the back of the Rose Theatre on a slightly different day to today. And if we were to try and walk our way through this, actually to achieve that task, we're facing a lot of what's called sensory noise. Now, we're not talking about sound per se. We're talking about a lot of unexpected activity with the people you see in the scene. And how we do that is based on our perceptions. And how we do that is to take our experiences of being in crowded situations before and try to predict what might happen. And also, we rely on social etiquette, how people are likely to behave in that sort of situation. And to do that, we need a nervous system that is not this. This is a couch potato. Descartes' ideas propose that your brain and your nervous system act rather like a cognitive couch potato, just waiting for information to flow into the system and then doing something about it. But what we now know, and we have a model called predictive processing that tells us something about this, is the brain and the nervous system are continuously predicting what's likely to happen to us. And we only use the sensory information to either confirm that those predictions are correct or to negate them. Now, if the sensory stimuli confirm those predictions, nothing needs to happen. We've got a relatively good model that can explain away what's going on. However, if we have negation of the prediction, then we send sensory signals up towards the higher centers. This is vastly different to Descartes' model, where information is transferred from the periphery up to the brain without any filtering or alteration. And what this really depends on is a series of models throughout the nervous system. And they're not made of wood, as this diagram shows, but they're made of neural networks and neural connections. And some of you will have read about the term plasticity, neuroplasticity. And some of you, if you have, will think this takes place over weeks or months or years. But this is a dynamic that happens all the time. In fact, one of the pleasures of standing here right now is I'm changing the way in which your nervous system is wired. And there's good news and bad news within that story, because neuroplasticity can be adaptive, can be fit for purpose, or it can be maladaptive, causing problems. We'll talk more about that in a second. And what we really get in that is regularities. Here I am with my friend, Albert Einstein. And what you're looking at is a mask of Einstein's face. And if I rotate his face 180 degrees, this mask, I don't know how well you can see it, but you're probably still seeing Einstein's nose come out towards you, even though what you're looking at is the concavity. I'll turn it around this side. And why is that? And that's because one of the firmest regularities you have, which is formed very early in development, is that noses come out from faces. And that's what we should expect. That's the regularity. In fact, you're probably worried every time you meet someone whose nose doesn't come out from their face. And you should be. But these are formed, these models are formed by interaction with our world and taking action on our world. Babies continuously play and interact with objects, putting them in their mouth because it's the first place in which they can sense objects. And we should continue to play, and we should continue to manipulate things, and we should continue to discover so that we broaden our repertoire of models as we develop. And have you ever wondered why, after going to the dentist and having a tooth extraction, you feel the huge desire, even though the dentist has told you not to, they get very shirty about this, to not put your tongue in the socket? But the reason you're doing that is to try and rediscover, to get a new mouthfeel, to try and find a new model of what your new mouth feels like. I noticed some of you made a small sound when you saw this. Some of you probably felt very uncomfortable. And that's because you're not just trying to make sense of yourself, you're also trying to make sense of other people you interact with. You're trying to make sense of situations you find yourself in. And an important thing in perceptions is that you can only ever attend to one perception at any point in time. There is no such thing for anybody, however talented they are, for dual tasking or multitasking. You can switch tasks quickly, but you can't concentrate on one thing more than another. And I would suggest that pain has primacy. You will attend to pain over other perceptions. If you like, pain cuts through the noise of daily life. So what's the value of thinking of pain as a perception? Well, it might make sense of situations where we know we can have pain without damage, and we can have damage without pain. So this is an example that was written up in a medical journal about 20 years ago now, where a builder jumped off some scaffolding and a nail, 15-inch nail, penetrated his boot. He was taken straight away by his colleagues to the accident and emergency department, showing all cardinal signs of being in agony, being in pain. He was vocalizing, he was very protective, he was sweating profusely. And he was taken off to the X-ray department. When he was brought back to the examination room, the doctor who was examining him swiftly removed the boot. He yet let out a yelp, but then immediately started to laugh. The doctor showed him the X-ray, and the nail had penetrated the space between the big toe and the second toe. It hadn't gone into any of his tissue at all. This is an example of pain without any physical damage or any stimuli. If Descartes was right, and pain was a sensation, there's no reason this would have hurt. Pain is a perception. And equally, the opposite is true. This is an example from the American Civil War. This guy's had his arm blown off by a cannonball. And the record that went alongside this said that he felt no pain at the time. He was incredibly serene and calm. And only 2 hours after he had the wound repaired, did he start to experience any pain and report pain. There's gross amounts of tissue damage here, but no perception of pain. Pain is a perception, not a sensation. And this has led some people, however, to think that all pain is in your brain. And this is quite an understandable assumption to make. However, I believe, and many other people believe, it's incorrect. This is a person who was born congenitally insensitive to pain. He only has small changes in their genetics that mean that they cannot put the first input of noxious stimuli, damaging or dangerous stimuli, from the periphery. And these people never ever have a pain experience. By the way, they generally die young. This person died when he was 21. And the reason why they probably never experience pain is they've never been able to formulate the models which underpin our perception of pain. Perhaps where all this comes together best is the understanding of placebos or nocebos, where we can give an inert compound like sugar or saline to somebody and do it in the right context, in the right environment, do it in a almost medically theatrical way. And many people will report an analgesic effect. But equally, there's an opposite effect, the nocebo response, where if people have negative attention, negative expectation, negative understanding of what the treatment's about, their pain, in fact, gets worse. So what does all this mean for the treatment of pain or the management of pain? Well, unfortunately, we're right at the edge of an abyss. In the US and in Australia, they've fallen the other side of the chasm. They're deeply ingrained in the opioid epidemic. We are really just about to fall into it if we don't do the right things. And unfortunately, there's no evidence that people are motivating forces to do those things. So people are dying because of our gold standard drug for pain. And many of the drugs and many of the other treatments we have for pain are formulated on this idea that pain is a sensation, not a perception. So could the idea that pain is a perception and not a sensation lead to newer and different forms of treatment? And actually, it already has. Many pain management groups around the world are employing the principles and the practice of meditation as part of their therapy. Now, the good news is you don't have to shave your head or dress in red robes or sit on a beach to be mindful. You can be mindful wherever you are. Many of you have probably been mindful right a second. I hope you are. All right? How does mindfulness work? We think that it improves the flexibility of those models that the nervous system builds. And pain, patients who suffer in pain often have very narrow response profiles to an whole range of stimuli that in most people wouldn't result in a perception of pain. But if they hear a loud noise or they're put in a threatening situation, someone comes close to a part of their body, they feel vulnerable. They have a pain perception, whereas we wouldn't normally expect them to have that. We think that that's due to narrowing of models. And this one may be one mechanism by which we can make those models flexible again. Equally, there are techniques of distraction, and this is a great example from the University of Washington, where they've used virtual reality and produced a program called Snow World to manage the pain of people who have had burns and manage them while they're having treatment for their burns. And it's intentionally a snowy, cold scene. It's intentionally blue in color. We normally relate heat and burns to red and to hot and heat. And this is intentional to cause distraction away from their ideas of pain and their perception of pain. And it's not new, actually. It was first really developed as part of hypnosis. And in the days gone by, hypnosis was a medical treatment, not a stage show media. So people used hypnosis in management of pain and other conditions well before Paul McKenna came along. And this is from my own work. And what we did is we established a thing called the rubber hand illusion. If we take most of you in this room and sit you down and make you look at a rubber hand and hide your real hand, and then stroke both the rubber hand and the real hand at the same time, most of you would start to embody, i.e. start to feel the rubber hand as your own. And what we did with this group of people is we established the rubber hand illusion. And then we checked whether or not they'd ever received acupuncture in their life before, and also if they knew what acupuncture did. And if they answered no to both of those things, then we re-established the rubber hand illusion, and then we put acupuncture needles into their rubber hand. And then we tested the sensation on their real hand that never had acupuncture. And we showed that their sensitivity to potentially painful stimuli like heat, pinprick, and certain types of chemicals were all reduced. They'd had an analgesic effect from a sticking needles into a rubber object. Now, if pain was a sensation, it wouldn't have made any difference. But because pain is a perception, we were treating some of these central models directly. And the news is not all bad for drugs, but maybe we need to be a bit more inventive. This is myself, fortunately or unfortunately, not having taken psychedelics. But psychedelics are proving to be a really exciting opportunity for us to use drugs again in the management of pain. And again, how do psychedelics work? Well, all of the literature on psychedelics tells us that they change and make models within the brain and nervous system more fluid, more amenable to change. They alter perceptions. And our early work together with the group in the Center of Psychedelics Research at Imperial College, we've got some early results that suggest that this might be a really beneficial thing to do with people. So I'd like to conclude my talk by saying that understanding pain as a perception and not as a sensation will enhance society's understanding not only of pain itself, but also of those people who are suffering ongoing pain, particularly those where we don't see any damage, who are told often they're crazy or putting things on. A better understanding of pain in terms of perception rather than sensation will facilitate better ways of managing patients, particularly those who have proved refractory to conventional therapies, who have had no response to conventional treatments. And lastly, together those things will help reduce the individual and societal burden of this thing we call pain, and hopefully will help us achieve a fundamental human right, which is to be pain-free. Thank you for listening.
Cool. Thank you, Mick Thacker. Always an amazing person to be able to listen to. And it was fun to be able to just have a little bit of a chat through some of the concepts in the chat box. But is there anything anyone wants to pull straight from that? Anything that was sort of like, whoa, fucking hell, that joined a couple of dots for me, or no, there's still, Luke, I'm not ready for this stuff. Either way, what is there? Is there anything that you took from that as an idea for shifting the paradigm around pain being a perception and not a sensation? First and foremost, straight off the bat, because one of the messages that I put in there is that the interventions for perception versus the interventions for sensation. I think this explains why a lot of people will butt heads around, well, I'm treating a sensation, well, I'm treating a perception. That idea and concept is older than Christianity. Sums up as mind over body. I'm interested in your thoughts, Victor. Do you want to share? Just open muse and any thoughts that you took from that? Okay, no problem. Well, I put a little note in there at different points just to be able to connect to things like, as I scroll back up through, through some of the interventions where it starts talking about mind-body practices and being able to talk about things like meditation or like stretching or any of these different types of interventions that make sense. And Victor, your comments in there suggesting that these ideas are older than Christianity, which is absolutely true. This is absolutely true. What is really fascinating then is the jump around how we treat people who come to us with an uncomfortable or a perception themselves of a sensation of a problem that they want our help with. And that, I think, is a really important bridge to be able to help patients to be able to get across. And I am not going to sit here and tell each of you how to work with the individual person that's in front of you. But as an example, I have sent that video to my clients and said, watch that and come in and ask me anything that didn't make sense, anything afterwards. That exact video to then come in and then to be able to explain how, look at so many of the things that people who have failed physiotherapy, they failed rehabilitation and exercise, they failed going to see different chiropractors, and they end up feeling that no one really understands their pain, is because they've been jumping from people who's been treating them from a sensation perspective as opposed to the perception. And that's why that then opens up for us to be able to have some interesting conversations around what they interpreted from a video like that, because the takeaway from shifting someone's perception is where we are updating beliefs, and that is so clearly been driven home from JP Kinneira's group, Peter Sullivan's group. All of these leaders are really talking about, the papers that I've been putting into here in working with the beliefs to be able to shift someone's top-down modulation through musculoskeletal rehabilitation. And that, again, I guess that doesn't make sense unless we're looking at pain as a perception as opposed to a sensation. Angelo, you wrote in here, in my experience, the light bulb has not gone off for patients immediately. It seems like it's a long process of convincing rather than immediate realization. And I'm going to break some unfortunate news to you, mate, is that that's not going to change, because your desire, my desire, everyone's desire is for a quick fix. And if there's a sensation, if there's something broken, then I can just come to you and you can just fix it for me. I don't have to take any responsibility. I don't have to change any of my behaviors. I don't have to look at the different things that could be contributing towards my nervous system and giving me this predictive processing of threat, which is, again, ties back to that paper that really led me to even think about sharing this video with you, the predictive processing. So being able to, in my experience, Angelo, and for everyone else in this room, I've really struggled. I found that with people who have really set beliefs, we spent the last session on soft skills and around this idea of different levels of beliefs. In 1, 2, 3 sessions, generally, I find that I'm not able to shift the needle. So that's why I work in a program-based format aligned with the cash-in paper we looked at last week, which looks at interventions over 12 weeks or more, because it takes time. And before talking about some of these things, I'm going to want to have introduced the metaphor of pain being like an alarm system, that hurt doesn't necessarily equal harm. Even though it is then touched upon in this video, it helps people to start rebuild new concept, new intellectual constructs and beliefs around what it is to interpret the sensations that are coming from their body, because then we are able to change it. Here is an example of utilizing and taking this material and trying to get it across in a really simple way using pain neuroscience education that I've developed to help myself do this, exactly what you're talking about there, to try and help nudge my patient towards seeing pain as a perception, is to be able to use pain neuroscience education. You guys have access to this. So this is, again, one of the questions that I was asked from the student as to how do I take this paper and actually go about implementing this with pain neuroscience education. And again, I'm going to assume that you haven't watched the video because you have got the video of me giving an example of this on Blackboard, but I am going to ask each of you to just do a little thought experiment, okay? And I'm going to, I can't see anybody because everybody's cameras are off, so I'm going to ask you to close your eyes. Now, I'm going to assume that every one of you is going to participate in this thought experiment and has your eyes closed, okay? And whilst you're doing this, I'm going to ask you to think about a grandmother of yours. I'm going to ask you to see if you can picture how she looks. What does she look like? I'm going to ask you if you can maybe visualize or remember a thing that you used to do with her. A really clear, vivid memory that you used to do with her. For example, I used to go and walk with my nan at the local lake and feed the ducks. Very vivid memory. See if you have one. I want to see if you can draw upon a smell that you can maybe associate with her. Bread in the oven would be maybe a very traditional one of someone associating with their grandmother, or it could be something completely unique, like something she used to buy you for Christmas or something. I want you to see if you can picture her. This is a visualization challenge. See if you can picture her moving. And I'm going to ask you to open your eyes, okay? Now, if you had participated in that little thought experiment there, what I would anticipate, or what we used to think, was that there used to be a little flag that would pop up in a certain part of your brain that would then say everything about what you just thought about your grandmother, what she looked like, what she smelled like, a vivid memory, how she moved, all of these things in the grandma part of your brain. But what we now know about how that process of memory that you just went through with your grandmother would have been that when you thought about her moving, this part of the brain here, fancy words, the motor cortex, would have lit up with metabolic activity if we had you in an MRI scanner. When you thought about that memory, like me, you were going and feeding the ducks, that would have lit up some of the fancy circuitry here around emotion. When you were able to see her, the visual part of your brain would have lit up. And this all lights up like a signature rather than a little map of one part of the brain that has all of that information. And whilst that might be a little bit disconnected as it is maybe a cartoon drawing, this would be what it would look like on an MRI scanner if I was to get you to think about your grandmother. This, by the way, is like a cross-section of the brain. You guys have done some MRI work in the unit just outside the clinic, I believe. I certainly had to when I was going through studies. And that is a quiet MRI. That's just you just sat there whilst nothing is happening. And as we ask you to think about your grandmother, there would be metabolic activity of the brain in all of these different red blobs around the brain that would have been associated with whether you were being able to picture her moving, whether you were able to see what she looks like, remember a food she used to make. And that's how we can make the leap to be able to suggest that all these different parts of the brain are involved, a little bit like a grandma signature. And that really is what I'm trying to suggest as a process for how all of our nervous system and our brain is involved with something so simple as what you just did there around thinking about your grandma. And Another way I like to be able to understand this is through training dogs, because it's something most people could connect with. I've actually been sharing the process of the last 6 months of utilizing this to try and influence the behavior of my dog. And it is a story of Pavlov's dogs. And this is something that most people are able to connect with. I'll ask you, have you ever heard of Pavlov's dogs? And most people will say, no, you haven't. Maybe I've heard about the ringing of the bells to be able to get the dog, something like that. And I'll say exactly, yes. So if we can picture this grandma experiment and apply this to the dog, what we have is the dog is able to see food, the dog is able to smell food, the dog has had a memory of that's food, that's a good thing, and it produces an output of salivation. You don't have to do anything. A dog will be born tomorrow, and that will happen as a preconditioned response. Okay, but now if what happens every time that the dog sees the food, the dog smells the food, and the dog hears a bell, what happens is this sound part, the auditory cortex in the brain, also is getting stimulated at the same time. So all of a sudden, what happens then is over a very short period of time, where I've applied not a bell, I've applied a clicker. And every time the dog sees the food and produces the output of salivation by the triggering of this little signature, I have very quickly wired in the bell or the clicker to produce salivation, which I don't even need to bring food out anymore. I can just ring the bell and my dog, Bernie Blue, will be looking for reward. He is in salivation mode in anticipation. His nervous system has predicted, based on its experience, that this output is appropriate based on all of the information. Really, really interesting to be able to understand this. This is called Hebbian Learning. And that's a term from Louis Gifford's Aches and Pains, that things that happen together, wire together, and we have this memory and prediction process that's going on. If we would apply this to, for example, bending down or a task, we would be able to say and have a plausible explanation for how we would have the movement. Has anybody in here seen Lorimer Moseley's snakebite story? I'm pretty sure I put it in and Paul would have drummed it across. And again, another one I use for patients to be able to grasp all of this idea as a memory prediction model for how Lorimer got to the point where the stick brushing his leg triggered off the memory, the context, what he could see, all of these things, and he had a pain experience. All based on this processing neurons that fire together, wire together as an idea for associative and conditioned learning. This is something that enables us to make sense of how we could have pain, not definitively, but we could have pain in the absence of an injury. This helps us how we could explain that in your individual experience, this neck pain that you've got, we have sensation that's coming from the neck. We have memory about what the pain experience has been in the past. We have the different things that are filling up your cup at the moment, your relationships, your job, your amount of sleep that you're having, all of these things that are going to affect whether your nervous system is going to be in protection mode or not. And the fact that we've had this previous experience and our nervous system has learned, that has to give us hope that if we can learn something, we can also unlearn it. This is the absolute definition of neuroplasticity, which may be a new name or a new word on you, but what it means is that our neurons, the foundations of our nervous system, are changing all the time, and that's got to give us optimism and hope around change and pain as well. As Mick Thacker said in that video, it should be a human right to be striving towards people being able to be pain-free. And it would be single-minded of me to be able to be looking at this and treating your unique pain experience as if it was as straightforward as a sensation coming in. We need to be looking at different things to try and help all the levels of letting this settle down. And that's where I'm going to invite you to be able to explore some mind-body practices that can start off really gentle and also is scope for what you might enjoy most. Anything from walking out in nature with your dog to being able to read a book in a coffee shop, being ultimately what is most enjoyable for you. And this very mechanism here around learned protection of a particular movement we could be talking about bending down to the ground. If we are able to change something about how you bend down to the ground, then that little signature that we just looked at and talked about, that is your unique representation of your grandmother, but also of your pain experience of bending, or your pain experience of lifting the shoulder overhead, of turning the head to the left, whatever it may be, if we can change something, because our assessments just ruled out that we don't think anything significant is going on, and you're telling me that we don't have any mechanism of injury. My thought process to do is to try and explore doing something differently. Now, from a walking perspective, that could be as simple as, right, we're going to walk on a treadmill, or we're going to walk outside. Same movement, but we're changing the context, and we want to see if that changes the outcome. Or we're going to try and bend in a different way. So I've got a few little tasks, or actually I'm going to start with some stretches that involve us exploring bending your back and seeing how that happens. And if we can violate your nervous system's experience of pain, then we could plausibly give your nervous system evidence of safety, and we find an entry to be able to move and gradually get going. Are you up for doing or having a go at some of these gentle exercises / interventions that we could do away from me as well? That is how how I would wrap up with that would be, you know, this little slide here shows that an unfortunate saying is that pain is, when we talk about these things, perception, people understand beliefs, etc., is that pain is in your head. Okay, and that is where I will always have to be able to check that somebody hasn't interpreted that as, oh, this person, Luke's just saying that this is psychological pain, because these changes, whilst what I've talked about here, are in the brain. These adaptations, as you can have a look at in the Tasmanian Pain booklet, happen at the spinal cord, they happen in the dorsal root ganglion, they happen peripherally in the skin and all of our tissues as well. So these are adaptations that can change throughout the entirety of the nervous system. So it's not that pain is in the head, it's just that we're dealing with a pain issue, not a tissue issue. And that then I would marry up with, I've sent them a little video, maybe Laura Mosley's snake bite story. I've sent them this discussion maybe of Mick Thacker, invited someone in to be able to have a discussion around anything that they did or didn't see. Then I've used Pain Neuroscience Education to just give a tangible connection to that otherwise really complicated stuff that's in that paper, to get to the point of simply treating this as a perception and exploring what someone might enjoy. And as Mick Thacker said in there, this updates all of the lowest levels of neurobiology right up to the whole organism. And we don't know and understand exactly why some of these will work. In fact, most of them, we don't understand why they'll work, but we are able to start bringing in the things that are in the guidelines around what might be just lumped into lifestyle and activity modifications, which everybody's going to accept. So yeah, I need to do a bit more exercise. Yeah, I need to drink a bit less alcohol. Yeah, I need to, well, this connects to give a little bit more tangible guidance. And this is some of the ways that I will use to help somebody take from this, like, what do you enjoy doing? Let's find a way to be able to get you to start doing that again. Let's find a way to try and do some of these things a little bit differently. Let's try and find ways to try and increase your positive expectation towards some of these changes. Again, placebo, nocebo, all of these types of things. I'm going to just have a look what's going on. Peter Johnson makes a lot of sense. I can relate to a patient who has a fear avoidance of deadlifting with resistance, as he remembers how he herniated his disc every time he goes to perform the lift now. And again, that instance there, Peter, I would hope that you would be able to take and work on the example of getting across this target concept I've just developed, so that you develop the ability to string the flow of this target concept, but then be able to come out of it to be able to connect to that exact example that is relevant that you've just talked about there. So you've talked about, as the situation is, the presentation or the task or the movement isn't bending down, it's more specifically, it's deadlifting. We can look about the memory and the experience and understanding, and there is an image of a herniated disc. Maybe they've seen a jam thing coming out of the spine, and all of these things that are going to be tying into that signature that is going to be either producing protection or not. And can we give that person a graded exposure this is exactly what that paper in fact, it was last week, you guys haven't had it. I'm going to put this paper I've just thought about now in this module this week as well, by JP Canero, which is, and Peter Sullivan and Laura Mosley and Samantha Bunsley and all the leaders, which is entitled A Roadmap to Safety Learning. It's exactly this mechanism and this basis of being able to find an entry, change the processing, and teach somebody to be able to learn safety rather than fear, because it's this exact mechanism that we're talking about here. So I'm going to put that paper in. The keen ones of you are going to look at that to be able to try and make sense of it. It's a big part of the internship that I'm teaching at the moment, because I feel quite certain, even whilst this stuff's quite complicated, that this is where all the leaders in the field are converging on. This is the approach that people are trying to wrestle with. Angelo, same here, Pete. He deadlifted after I saw him twice with no pain. Yeah, it was strange, as he is a pro wrestler but never gets pain wrestling, but sometimes after. My thought was that because he's distracted and the pain was never initiated in that environment, that's why. Starting to talk about some plausible mechanisms now, and that's really really positive to hear and see. So that's as much as I really have planned to be able to share with you. I will be happy to take any questions or to field anything that you guys have in here. I hope that you enjoyed Mick Thacker's video there. I hope that this has maybe connected some dots around some ways to be able to work with this. To be able to tie the different exercises that you might hang to this will depend on your exercise repertoire and things that you feel comfortable doing. Okay, so if you feel comfortable being able to give someone some stretches or yoga, then this might be how you might start to be able to just do some gentle stretches or poses to be able to, or not even yoga. Maybe it's the McGill Big Three that we talked about for you guys in year 3 last year, or it could be the Mackenzie directional preference. Again, I think that what I tried to do a job there was that we're really trying to give people a exposure to symptom modification in those directional preferences rather than moving a disc in a particular direction. I think that we're probably doing symptom modification with that in terms of finding an entry to movement that somebody can then move forwards with. The issues that I have with something like that would be the narrative that goes with it. So again, the movements that are in Mackenzie I think are great. They are things that are going to be used often. It's just the communication around why we might be giving some of those exercises that might be potentially nocebic if we're attaching the old-fashioned disc derangement idea to that. But really, the exercises that you would give to this would be based on your experience. And again, I don't want you to get too hung up on this, because the intervention could be you prescribing walking. Aaron Kubel, who was graduated last year in America, he as part of the internship, and was chatting last internship around how he's working with this evidence base for people in pain, and he works with a purely online, where he does the consult to be able to gather people's beliefs and try to give some guided education to try and help people challenge their mental constructs of what their pain means. And then he works with people via email support. He's that disconcerted about the specificity of the exercise. So again, that is where hopefully you can watch this video, start figuring out, maybe look back on some of the things I've shared with you around how you connect, because again, all the different target concepts I have filmed and uploaded for you. And if you were one of my students personally, I would be setting for you to learn these things inside out, so that you have the framework of delivering the content, the target concepts, and then being able to adapt them to the person that's in front of you. But you have developed your storytelling with these as a vehicle, because you need to, as I said right at the start here, not all of you are going to want to go into teaching, but if you're going to work with patients, unfortunately, a big part of it's teaching. So really, we all have a bit of a responsibility to develop our ability to do pedagogy. So would you say not to bother with looking into strength curves profiles for exercise selection? Strength curves profiles, sounds like you're talking about strength and conditioning variables there, Angelo.
Yes, Tom it is. Yeah, just on the term, just on thinking of specificity and stuff, like in terms of like geeking out and training and that kind of stuff, like strength curves and hitting muscles in different areas, and that kind of, whether to bother maybe incorporating that in kind of rehab stuff.
Yeah.
You know, thinking about being too specific on, you know, there's no need to be specific in that regard. That's what my question was.
Great question. So let's just get crystal clarity here. It's worked out very well that the webinar I've put alongside this on Blackboard for you guys to look at between now and next time is my general loading principles, which is absolutely, you know, working from isometrics through to endurance, through to strength, through to power, from a way to return somebody from static load to high and fast load. So the reasoning around why we might do an intervention, again, comes back to that, is important. From a general public aches and pains, the evidence-based answer around strength curves and profiles is no, doesn't matter. What matters is, what does that person need to be able to do? It's why I shared the grandfather picking up the daughter's video to be able to say, right, as an individual needs analysis, what does this person's end goal need to be able to do? Or they want to lift this granddaughter up from the floor. How heavy is she? Okay, she's 20 kilos. So we need to, this person's requirement of their back is that they need to be able to lift 20 kilos. Very different if you're working with me and I came to you with my back pain and my worry about my deadlift injury just before Christmas with 260 kilos. So you're going to look at it and say, okay, so the strength curves and profiles for this person, their rehab is that they want to get back to doing that. So that becomes then important. In the persistent pain in limbs like tendinopathy, targeted strength seems to be a bit more important than with back, neck and shoulder pain. So we can look at the data and the research and say people with Achilles, there seems to be some good evidence that 1.4 times body weight for 6 reps seems to be generally protective across the board, especially when we're looking at people who do any sort of running, recreational runners right the way up. Similar with the knee, there seems to be 40 to 60 kilos produced by Pete Malliaris's group as a goal for patellar tendinopathy to be able to get to strength. Those numbers become really helpful to be able to get somebody back to and beyond that as part of the rehab process. When it comes to back pain, it's much more individual. There isn't a strength requirement across the board that anyone has been able to establish. So it becomes much more around trying to give people, calm things down, gradually get going, and the rate at which we would develop, the loading or reloading is going to be more important. If you're working with an athlete or someone wants to get back to lifting, then strength curves, etc., might become part of the end goal. Does that sort of make sense, Tom? Top man. Peter Johnson, how long has this module been taught at USW? As I don't hear too many grads talk about it yet, I think it's so beneficial. Also, do you think for the younger years there should, or is there a change in modules, like removing our biomechanics or bringing in a pain and psychology model? It's a good question, Peter. So I first come back to WIOC in, I feel like we have that now, Pete. I come in 2018 and started doing some lectures just with the 4th years, a bit like you are now, and me and Paul were both doing that. And then since then, this year is the first year that we have been able to make any sort of nudge from year 1. So year 1s now get our pain science. So stuff like this, what I'm sharing with you, is what we're trying to get to year 1, so that you're not having it in final year. It's being like a bit of a paradigm shift. We're trying to get it so that, okay, this makes sense. This is where the field is at. Okay, how do we work with it? How do we actually create programs and interventions? And if you were to speak to Paul, drop him a message. If you were to look at year 3, year 2, I was teaching year 1 yesterday covering. If you were to look at the things that are in year 1, unfortunately, it's reality. I think that most people are not going to get round to watching it because the indicators of some of the things that I'm teaching, this module, for example, is not examined. So most people, I was a student once, most people just want to know what's in the exam, and that is all you can really process without getting overwhelmed. So until we can get these things that they are a main part of exam, I think that it's not going to be given the weight that it perhaps, in my opinion, should have. And if you were to speak to Paul and have a little look back at the clinical management modules, there's content like this everywhere. The thing is then being able to help people to actually watch it. Super stuff. Okay, so what I will do is, it's as we've run over now, I will leave between now and next time. If there's any questions that come in from the loading principles, Tom, I'm thinking you in particular, based on your questionnaire, you might find that particularly interesting. And if there's anything that I get as a consensus between now and then, I will guide what I put into our live class here, like as to what that's based on, and I'll release some more of my pre-recorded loading lectures after that for the final two classes. Okay. Thanks for the interaction, guys. I hope you enjoyed it. I've enjoyed watching that. I always like any excuse to watch Mick Thacker in my busy schedule as well. So thanks for giving me the opportunity to watch that. I will update the Blackboard between this class, and I've got to run this class again now in an hour, so it will all be on there within the next couple of hours. There's a podcast, if anybody who is interested, called Behind the Movement, which is a lot of the leading movement teachers in the world, from martial arts, dance, to all of these things. They filmed the podcast with me. It's on Spotify by Kyle. Great. Behind the Movement, that's going to be going out in the next couple of days. You guys might find that interesting, me talking about trying to bring these things into a university curriculum, because let me tell you something, it's not easy. I'll see you guys, and I'll look out for any messages. Take care. Ta-ra.